Greetings of the day. My name is Dr. Ketav Tushar Lakhia. I am Associate Professor in CVTS Department, UN Mehta Hospital. So my today's topic is on mitral regurgitation. So first we will go through the mitral valve anatomy. So mitral valve connects the left atrium and the left ventricle. It opens during diastole to allow the blood flow from left atrium to the left ventricle. During ventricular systole, the mitral valve closes and prevents the backflow to the LA. So normal function of the mitral valve depends on the mitral valve complex, which is made up of mainly three components: mitral valve, left ventricular wall, and left atrium. Mitral valve again is divided into mitral annulus, mitral leaflets, and subvalvular apparatus. The subvalvular apparatus consists of the chordae tendineae and papillary muscles. All of the components of mitral valve complex takes part in the normal function of the mitral valve. So this is the schematic diagram showing the mitral valve anatomy. Here you can see this is the mitral annulus, this is the left atrium area, this is the LV area, and this is the mitral valve complex. So this is the mitral annulus, leaflets, and the subvalvular apparatus consisting chordae tendineae and the papillary muscle. This is the view which we can show after opening the LA. So this is the anterior mitral leaflet and this is the posterior mitral leaflet. So starting with the etiology and pathophysiology of mitral regurgitation. Mitral regurgitation is defined as an abnormal reversal of blood flow from left ventricle to the left atrium. It is caused by the disruption in any part of the mitral valve apparatus which we have seen previously. So in the etiology of mitral valve, any of the mitral valve apparatus components may be involved. So abnormality of any of the structures of the mitral valve apparatus, what we have seen earlier, can cause MR. Mitral regurgitation can be classified as acute or chronic, or primary or secondary. Now the causes of acute MR, it may be related to the mitral annulus disorder, which consists of infective endocarditis, which may be related to the abscess formation in the mitral valve, trauma, which can be caused by the valvular heart surgery or because of the blunt chest trauma. Third is the paravalvular leak caused by the suture interruption, which may be seen after the mitral valve replacement. So there may be a surgical technical problems, or there is infective endocarditis which may cause the paravalvular leak. The second thing is the mitral leaflet disorders which can cause acute MR. The causes are infective endocarditis involving the leaflets, which may lead to either perforation or interfering the valve closure because of the vegetation. It may be because of the trauma, the tear which may be caused during the balloon mitral valvotomy procedure or penetrating chest injury. The other causes are tumors like atrial myxoma, the myxomatous degeneration of the mitral leaflets, or systemic lupus erythematosus. One of the cause of acute MR can be rupture of the chordae tendineae. Now this rupture can be because of the various causes. It may be idiopathic, that is a spontaneous rupture due to myxomatous degeneration that may be caused in either mitral valve prolapse, Marfan syndrome, or Ehlers-Danlos syndrome. It may be because of infective endocarditis, acute rheumatic fever, or because of the trauma, BMV or blunt chest trauma. Next comes is the papillary muscle disorder which can cause acute MR. The causes are the ischemic MR because of the coronary artery disease. Now the coronary artery disease causes the dysfunction and rupture of the papillary muscle which leads to the acute MR. Another cause is the acute global left ventricular dysfunction. Another cause is the infiltrative diseases like amyloidosis and sarcoidosis and trauma. There may be primary mitral valve prosthetic disorders like bioprosthetic cusp perforation due to endocarditis, bioprosthetic cusp degeneration, mechanical failure of the valve, that is either the strut fracture or immobilized disc or ball of the mechanical prosthesis. Now coming to the etiology of the chronic MR, it may be inflammatory causes like rheumatic heart disease, systemic lupus erythematosus or scleroderma, infective causes like infective endocarditis affecting either normal, abnormal or maybe prosthetic mitral valves. In the degenerative causes of chronic MR, it may be because of myxomatous degeneration of the mitral valve leaflets, that is mitral valve prolapse, Marfan syndrome, Ehlers-Danlos syndrome, Xeroxanthoma elasticum, or calcification of the mitral valve annulus. There may be some structural causes which can cause chronic MR, like previously we have already seen that ruptured chordae tendineae, rupture or dysfunction of papillary muscle, or dilatation of mitral valve annulus with left ventricular cavity. Another structural cause can be because of hypertrophic cardiomyopathy or paravalvular prosthetic leak. The congenital causes of chronic MR are mitral valve collapse or fenestration, parachute mitral valve abnormality in association with endocardial cushion defect, endocardial fibroelastosis, transposition of great arteries, that is TGA, or anomalous origin of the left coronary artery. Now we will discuss the pathology of the mitral valve regurgitation. As we have already discussed, mitral valve regurgitation is classified as primary and secondary. Primary mitral valve regurgitation is caused by an abnormality in the mitral valve itself. However, secondary mitral valve regurgitation is caused by an abnormality in the left ventricle of the heart. The most common cause of mitral regurgitation in United States is myxomatous degeneration of the valve. However, most common cause of MR in India is rheumatic heart disease. Myxomatous degeneration. So, as you can see, in the myxomatous degeneration, it causes the stretching out of the valve leaflets and the chordae tendineae. So, this leads to elongation of the valve leaflets and the chordae tendineae. So, this prevents the leaflets to fully coapt when the valve is closed. So, this causes a prolapse of the valve leaflets in the left atrium and thereby ultimately causing mitral regurgitation. In the rheumatic MR, the pathology would be the chordae are thickened and foreshortened, which leads to restrictive leaflet motion. Along with there is posterior annular dilatation, as you can see in this figure, which ultimately leads to mitral regurgitation. So in ischemic MR, there is ischemic dysfunction of the papillary muscles along with dilatation of the left ventricle, which leads to subsequent displacement of the papillary muscle. And there is also dilatation of the mitral annulus. This will lead to the MR. So this is the basic pathology in ischemic MR. So here you can see this is the normal mitral valve leaflets. So this is the LV, these are the papillary muscle, and these are the chordae, and the normal mitral annulus, which leads to the normal coaptation of the mitral valve without any mitral regurgitation. So in ischemic MR, there is ischemic LV distortion, which leads to the dilatation of the left ventricle. There is displacement of the papillary muscle along with the elongation of the chorda, restricted leaflet closure, annular dilatation leading to MR. In secondary mitral regurgitation, there is dilatation of the left ventricle which causes stretching of the mitral valve annulus and displacement of the papillary muscle. Now this dilatation of the LV can be due to any cause of dilated cardiomyopathy, including aortic insufficiency, that is aortic regurgitation. It is also called as functional mitral regurgitation because the papillary muscles, chordae and the valve leaflets are usually normal. Here we will now discuss the functional classification of mitral regurgitation. The Carpentier has given a functional classification of mitral valve disease, which is used to describe the mechanism of valvular dysfunction. Now this classification is based on the opening and closing motion of the mitral leaflets. It is divided into three types: type 1, type 2 and type 3. Type 3 is further subdivided into 3A and 3B. So in type 1, the leaflet motion is normal. In type 2, there is excess leaflet motion which leads to leaflet prolapse. And in type 3, there is restricted leaflet motion. So it is further subdivided into, if it is restricted opening, then it is 3A, and if it is restricted closure, then it is 3B. So here you can see this is the type 1 where there is valve dysfunction with normal leaflet motion. Here the type 2, there is a leaflet prolapse, excessive leaflet motion leading to the mitral regurgitation. The type 3, so here there is restricted leaflet opening, and here it is restricted leaflet closure. So along with the type, we can correlate the etiology. For type 1, that is normal motion, the ischemic heart disease, dilated cardiomyopathy, endocarditis and congenital pathology are usually of type 1 MR. In type 2, the causes are mainly the degenerative diseases like fibroelastic deficiency, Barlow's disease, endocarditis, rheumatic disease, trauma and Ehlers-Danlos syndrome. Type 3A, mainly the rheumatic disease are of type 3. Another causes are carcinoid syndrome and radiopathy. In type 3B, it is mainly because of the either ischemic heart disease or dilated cardiomyopathy. So the pathophysiology of the mitral regurgitation can be classified into three phases of the disease process: the acute phase, the chronic compensated phase and the chronic decompensated phase. So here we can see, so this is the normal LV where the routine from blood flows from LA to LV and from LA to LV to aorta. So in acute mitral regurgitation, usually there is acute failure which leads to acute volume overload. So the LA pressure increases which leads to pulmonary edema and the acute symptoms arises. So in chronic mitral regurgitation, usually in the chronic compensated phase, there is not sudden overload, there is gradual volume overload which leads to dilatation of the LA with normal pressure initially. Now in this stage, patient may be asymptomatic or may be having some of the features like fatigue, but then if this in this phase usually the EF is increased than more than 60%. In decompensated chronic mitral regurgitation phase, usually the dilatation capacity of the left atrium is decreased and it is overstretched. So whenever this compensatory phase gets over, there is decrease in the forward flow and the EF usually is reduced, and which ultimately leads to decompensated phase and pulmonary edema. Coming to the clinical manifestations, now it depends on the phase of the disease. In acute MR, there is signs and symptoms of decompensated congestive heart failure, that is shortness of breath, orthopnea, paroxysmal nocturnal dyspnea, that is PND, and pulmonary edema. There may be symptoms of low cardiac output like decreased exercise tolerance and palpitations. In chronic compensated MR, patient may be asymptomatic with normal exercise tolerance without any symptoms of heart failure, or there may be signs of early disease like fatigue, shortness of breath or dyspnea on exertion. Palpitations may be there if atrial fibrillation has been developed. In the late stage, there may be symptoms of congestive heart failure with pulmonary edema. On physical examination, on auscultation, there will be soft S1, laterally displaced apex beat with heave. A murmur will be heard mainly in the apical area. So this will be high pitched holosystolic murmur at apex radiating to axilla and best heard in left lateral position. Third heart sound may be heard and atrial fibrillation may be present. So on X-ray, there will be findings of cardiomegaly. There will be straightening of the left heart border, the LA enlargement, the LV enlargement, and there may be signs of pulmonary venous congestion. On ECG, there will be P mitral suggestive of LA enlargement, atrial fibrillation, and features of left ventricular hypertrophy. Echo is the mainstay of the diagnosis for the confirmation of MR. So on echo on color Doppler flow in transthoracic echo, there will be a jet of blood will be seen flowing from LV to LA during ventricular systole. There will be dilated LA and LV. The LA and LV are dilated and the LV function will be decreased. The ejection fraction will be low. On echo, we can see the valve morphology, the severity of regurgitation, atrial ventricular function, and there may be vegetations which is primarily better seen on transesophageal echo. So how to grade MR on echo? So two main things are measured, that is regurgitant volume and effective regurgitant orifice. So regurgitant volume less than 30 and ER of less than 20, that would be grade 1. 30 to 44 cc regurgitant volume and ER of 20 to 29 is grade 2. 45 to 59 cc regurgitant volume and ER of 30 to 39 mm square is grade 3. And grade 4 is when regurgitant volume is more than or equal to 60 cc and effective regurgitant orifice is more than 40 mm square. So now coming to the classification of the disease severity in adults, we have already seen various parameters on echo. So just to add, the Doppler vena contracta width, that would be less than 0.3 in mild, 0.3 to 0.69 in moderate, and more than or equal to 0.7 in severe cases. Other rest of the parameters we have already seen. However, in severe cases, the LA and LV size would be enlarged. Now coming to the treatment of mitral regurgitation. The medical therapy includes the following. Afterload reducing agents and diuretics help in symptomatic relief or in case of LV dysfunction. The beta blockers are for primary treatment of LV dysfunction in functional MR. We have to consider insertion of intra-aortic balloon pump in case of acute MR with hemodynamic compromise and acute LV failure. In the presence of atrial fibrillation, beta blockers, calcium channel blockers, digitalis, or a combination of any should be used. The prophylactic antibiotics before any dental procedure involving manipulation of gingival tissue, periapical region of a tooth, or perforation of oral mucosa in patient with prosthetic heart valve, previous infection, previous endocarditis, some form of congenital heart disease, or valvulopathy in cardiac heart transplant recipient. Consideration of ionotropic agents in chronic severe symptomatic MR should be done in consultation with a CTVS surgeon. Now, what are the surgical treatment options? The primary surgical treatment is mitral valve replacement, which may be either open or minimal invasive. The valves, that is the prosthesis, can be used is either bioprosthetic or metallic valve. Another mode of therapy is the mitral valve repair, where the repair is possible. It can be either open, minimally invasive, or robotic assisted. It may be either suture annuloplasty, ring annuloplasty, or combination of both. Now the stages of chronic primary MR. It is divided into 4 stages: A, B, C and D. Stage A is the patients who are at risk of MR. Stage B, that is progressive MR. Stage C, asymptomatic severe MR, and in stage D, it covers symptomatic severe MR. So this is a diagram and flow chart showing the various treatment plans for which patient which therapy is indicated. This is according to the 2020 ACC/AHA guidelines. So in case of primary mitral valve regurgitation, and if there is severe MR, that is vena contracta of more than or equal to 0.7 centimeter, regurgitant volume of more than or equal to 60 ml, ERO of more than 0.40 centimeter square. So now this can be divided into two, either symptomatic or asymptomatic. In case of asymptomatic severe MR, which is stage C, it is again divided into two parts. If the LVEF is normal or LVEF is decreased. So if asymptomatic severe MR with decreased LV ejection fraction less than 60% and end systolic diameter of LV of more than 40 mm, it is the class 1 indication to go for the mitral valve surgery. In this, if there is degenerative mitral valve disease and successful and durable repair is possible, then mitral valve surgery should be performed at either primary or at a specialized center. In case the etiology is because of the rheumatic mitral valve disease, then MV repair should be performed at a specialized center. But it is a class 2B indication. However, where in case of rheumatic mitral valve disease, it is if the valve is not repairable, then it is better to go for mitral valve replacement. If asymptomatic severe MR with normal LV function of more than 60% or end systolic diameter of LV less than 40 mm. Now there are two conditions. If expected surgical mortality of less than 1% with more than 95% likelihood of successful and durable repair without any residual MR, if it is there, then MV repair at the primary or CVC should be done, which is a class 2A indication. If there is progressive increase in LV size or decrease in LVEF on at least 3 studies, then NV repair or replacement is to be done. That is class 2B indication. In case of there is severe MR with symptoms, that is stage D, that comes in symptomatic severe MR. Regardless of the MV function, the patient should be given the choice of MV surgery. And in this case, if there is a high or prohibitive surgical risk with anatomy favorable for transcatheter approach and life expectancy of more than 1 year, only in those cases transcatheter age-to-age MV repair should be preferred, that is class 2 indication. In this, Mitra clip can be used. Now what are the indications for surgery for MR? So we have already seen a brief overview of and the flow chart for treatment of mitral valve surgery. So these are the current criteria used to define mitral regurgitation as severe that we have already seen, that is the regurgitant volume of more than 60, regurgitant fraction of more than 50% and effective regurgitant orifice of more than or equal to 40 mm square with vena contracta of 0.7 centimeter. So any patient who has severe MR with NYHA class 3 or 4 symptoms, EFO less than 60, ESD of more than 45, 40 to 45 and end systolic volume of more than 50 ml per meter square should be done surgical repair or replacement. So any patient with severe MR, even if there are no symptoms or no signs of LV dysfunction, as low as the operative risk is low and good chance of valve repair, should go under the surgical repair or replacement. However, in valvular repair, the intra-op TE should be available. Now consider waiting for signs of reduced LV function in patients with less than severe MR high operative risk due to comorbidities, and if there is likelihood of successful repair is low. Now, why to choose MV repair over MVR? Because there is lower operative mortality, improved long-term survival, better preserved left ventricular function, and lower incidence of thromboembolism, bleeding and endocarditis. That's why MV repair is preferred over MVR wherever feasible and possible. Now, what are the factors which decrease the likelihood of MV repair? These are either annular calcification is there, usually in case of rheumatic disease, and there is specific anterior leaflet dysfunction. Now, in such cases, the likelihood of MV repair is less. So, on case-to-case basis, this patient should require mitral valve replacement instead of mitral valve repair. Now, pre-operative assessment, all the echocardiographic assessment should be done, including leaflet mobility, LV function, LA size, and valvular characteristics. This should be done pre-operatively. All the patient should undergo intraoperative assessment as well, that is systematic evaluation of the valve as well as assessment of all the mitral valve apparatus, that is LA, LV, valve leaflets, chordae, annulus, and papillary muscles, etc. Now, what is the goal of mitral valve repair? Now, the goal is not to return valve to a normal anatomic structure, but goal is to achieve a satisfactory functional result. Now, lesions encountered and the probability of MV repair. In case there is only annular dilatation, the probability of MV repair is very high. In case of caudal rupture or elongation, still MV repair is preferred. However, if there is subvalvular fibrosis, the possibility and the success ratio of repair is low. So, such cases should be evaluated on case-to-case basis and should undergo mitral valve replacement. Now, this slide shows that what is the probability of the mitral valve repair according to the etiology. So, the success ratio of mitral valve repair is highest if there is degenerative cause as a etiology of mitral valve. It can be as high as 80%. Also, the second is the ischemic MR, that is 70%. In congenital causes, it is 60%. However, in rheumatic and infective etiology, the probability of repair is on the lower side, that is in rheumatic only 40 to 50% and infective it is 20 to 25%. So, MV surgery is not indicated for asymptomatic patients with mitral regurgitation and preserved LV function, that is EF is more than 60% and end systolic dimension is less than 40 mm, in whom there is significant doubt about the feasibility of the repair. And second is isolated MV surgery is not indicated for patient with mild or moderate MR. So, in these two cases, the surgeon or the clinician should wait for intervening, and as per the criteria, the patient should undergo either repair or surgery as and when required. So, now coming to some of the newer methods for the treatment of mitral valve disease. So, transcatheter mitral valve replacement can be done. Here you can see the catheter is inserted and a valve is inserted here from RA to LA, and then it is inserted. The second method is Mitra clip, that is transcatheter mitral valve repair with Mitra clip therapy. Here a clip is inserted in the middle of the valve, so that leads to the opposition of the valve. This procedure can also be performed transcatheterally. So, those patients who have pure mitral regurgitation and who are high risk for the surgery can be operated via this method. So, conclusions: degenerative mitral valve disease predominates and it is amenable to repair in more than 90% of the cases. MR should be surgically managed once severe, even if patient is asymptomatic and LV function is normal. Exposure a standardized approach and intra-op TE are key to successful MV repair. And if we are doing mitral valve replacement, preserve caudal attachment whenever possible. We can also do a newer methods like minimally invasive, robotic assisted, or even transcatheter approach wherever feasible on case-to-case basis. Thank you.